Welcome to They Didn't Teach Us This in Sex Ed, the official podcast from the Society for Reproduction and Fertility. How much period pain is normal and when should it raise a red flag? To find out, I'm joined today by Senior Clinical Research Fellow and Honorary Consultant Gynaecologist Dr. Lucy Whitaker to explore endometriosis, a condition that affects millions but is still frequently misunderstood. We'll dive into what we know about endometriosis, what we still don't understand, and how cutting-edge research is changing the picture. We'll also look at the signs that are often brushed off as normal, but shouldn't be. Dr. Lucy Whitaker, welcome.
Hello, thank you for having me.
Thank you for coming. So we might as well get stuck straight in at the beginning. Your research focuses quite heavily on endometriosis. So could you tell our audience what actually is endometriosis?
So endometriosis is when you get cells really similar to the lining of the womb but elsewhere in the body. So commonly it's lining the pelvis, they form these little lesions, they get really inflamed and they can cause really debilitating pain, lots of other symptoms and also infertility. It's a really miserable condition and it affects 1 in 10 women and those assigned female at birth. So it's really common, but lots of people haven't heard of it.
Yeah. So how do the cells get out of the uterus, or the uterine-like cells get to other places in the body?
So every month when someone has a period, so you get shedding of the lining of the womb, and most of that comes out through the vagina and then onto whatever period products you're using and then disposed of. But some of it will actually go up through the fallopian tubes and go into the pelvis. And that's a really common thing. That happens to about 90% of people, and we call it retrograde menstruation. And in most people, these, part of the period blood and all the cells that come with it, that'll just be seen by your immune system and cleared away and disappear away. So, but we think in about 10% of people that doesn't get cleared away. And so there's cells that are very like the lining of the womb and essentially were the lining of the womb. So they stick onto the side of the pelvis. And then from there, they can start to grow and the cells increase in number. It grows its new blood supply into these lesions, but also you start to develop nerve fibers coming in. And so you get these little areas that look exactly like the lining of the womb, but in the wrong place. And then over time, you get more and more inflammation. They go through these same cycles, and the way that your lining of the womb will respond to the changes in hormones across your cycle. And so when you get that withdrawal of progesterone, which causes the period to start, that causes lots of inflammation in the lining of the womb, but it also causes inflammation in these lesions. And so over time, we can get lots of scarring in this way because it doesn't heal in the same way that the lining of the womb does every month. And so they get really scarred, and also they can then start causing things to stick together.
That sounds quite painful. So I imagine pain is one of the key symptoms of the disease.
Yeah, so that's one of the hallmarks of it. So most people with endometriosis will typically start off having really painful periods, often quite heavy periods as well. But you can get lots of other pain symptoms. So you can get pain when you poo, pain when you pee, pain when you have sex. Your bowels can often become quite irritable. Your bladder can become irritable. But also it's a really inflammatory condition. So you can get lots of systemic features. So people can get a lot of fatigue. So can be absolutely exhausted. And also increasingly recognizing symptoms like brain fog. And you can imagine living with all of this has a really severe impact on people's mental health. But I think pain very much is the hallmark of it. But equally, there are many things we don't understand about endometriosis, but one of the things we don't really understand is that some people will have endometriosis, not have any symptoms. So we often find it when people undergo surgery to have a sterilisation. So they've completed their family, they don't want to have children in the future, and they have their tubes clipped as a contraceptive procedure. And these people have never had bothersome periods. They've been fertile. And then we look inside and they've actually got loads of endometriosis and weren't particularly symptomatic. And similarly, we can find people who are going through fertility investigations. They're diagnosed with endometriosis as part of that. But again, their periods haven't really been that problematic in the past. So we don't really understand why there's this disconnect between the disease we see and the symptoms that people experience.
And is that part of your research focus in trying to understand the differences between people without endometriosis and people with endometriosis, but who do and do not have symptoms?
I think we're trying to better understand the different symptoms that people will experience. I think we broadly, at the moment, focus has always been on people who are symptomatic, because if someone's not symptomatic, then actually we don't really need to do anything about this endometriosis if it's not causing them any problems. So, but what we're trying to get better at is trying to understand, in terms of the symptoms someone experiences, whether or not they predominantly have bowel symptoms, or it's symptoms around their period, or it's a very irritable bladder. Is there differences in the biology between those different people that might then have implications for how we treat the disease. Rather than at the moment, we'd use pretty much a kind of one-size-fits-all approach to our treatments, even though recognising people will have different subtypes of disease, different symptoms, and also different requirements of what they're looking for from a treatment.
I mean, I guess I always just assumed that your symptoms would be related to where these endometrial lesions were in the body, but I mean, that's maybe a bit of a simplistic.
You would think, but you can have people with lots of disease really close to their bowel and actually they don't have bowel symptoms, and somebody can have lesions overlying over the bladder and their bladder's fine. But you can also have people who've got disease nowhere near those things and they've got terrible bowel symptoms or terrible bladder symptoms, and probably some of that's to do with that general increase in inflammation you get within the pelvis, nerve fibres becoming sensitised, the bowel becoming really irritable. So even though the disease isn't actually on the bowel, they've got lots of bowel symptoms because that bowel is just starting to become a bit more problematic and troublesome and not responding to signals in the way it should do. And similarly, you can have some association, particularly if people have got a lot of cyclical chest symptoms. So every month they get a lot of pain in their shoulder tip, or they cough up blood, or they have a lung collapse.
Wow.
This is quite a rare variant of endometriosis, but that's often associated with endometriosis on the diaphragm, which is one of the rarer variants of endometriosis. But we don't truly know how rare it really is because we're so bad at testing for endometriosis because we don't have very good tools for that.
And you mentioned at the beginning that a lot of people don't really know about it or don't understand about it. And I guess that's one of the reasons we do these types of things, like you come and talk to people so that they can understand a wee bit more. So how would somebody listening to this podcast realise if they did have endometriosis, or if it's something that they should consider getting looked into?
I suppose it's that thing of should they be seeking for help with their symptoms. So anyone whose period is stopping them doing what they want to do, that's not normal. So if you're missing school, you're missing college, you're missing work because things are so sore, or equally if your periods are very heavy, that can be a symptom of endometriosis, but lots of other things can also cause heavy periods. But again, if you're leaking onto your clothes, passing clots, that's not normal, and that's a sign that you should go and seek help from a GP. I think often we focus on those very cyclical symptoms, so pain around your period, pain around ovulation. But I think one of the important things to know is that with endometriosis, often over time you lose that cyclicity of your symptoms. So people then have pain all the time or have these really unpredictable pain flares. And so sometimes they think or are told, oh, it can't be endometriosis because it's not purely related to your period. And that's not true.
Right.
So over time, that loss of cyclicity of symptoms is quite common with endometriosis. All people continue to experience symptoms even when their cycle's been suppressed with hormone treatment.
Yeah.
But really if you can't do what you would like to do because of your gynae symptoms, whether or not that's problems with your bowel, problems with your periods, sex being too sore, then that's not normal and you should seek help.
Yeah. And you took part in a recent documentary that I think showed beautifully the personal experience that a lot of women with endometriosis have. And I was quite struck at the level of impact it was having in their day-to-day life. You know, I think sometimes we talk about period pain or painful periods, and we don't really understand the severity of what a lot of women go through. Do you experience that with the people that come to your clinic?
Oh, the people I see, it's typically really impactful on them. So they're missing work, they've missed school, they've missed the time at university. They've had to change what job they're in or leave their job altogether. So 1 in 6 people with endometriosis will leave the workforce because of their symptoms.
Wow.
But one of the things I always find really difficult is the impact on relationships or people's aspirations for the future. So whether or not that's fertility or even, their day-to-day relationships with their families, with their friends, but also with their partners. And I think one of the things we're not good at talking about is problems with sex, and particularly painful sex. And I think whether or not that's shame, embarrassment about talking about these things, I think also what expectations of what a normal sex life is these days has become complicated and perhaps unduly affected by what we see in various types of media.
Yeah.
But people don't talk about it, and it can have a huge impact on relationships. We see marriages breaking down, and I find that really sad when actually there's lots of things we could do, but people just didn't want to talk about it or weren't asked about it. And I think that's ensuring that when people do present with symptoms that we are really methodical in all the different areas that we need to ask about, because sometimes people just fixate all on the periods, or if someone's coming through a fertility journey, going fixate all on the getting pregnant, but actually going, well, all these other things can be really debilitating and really embarrassing. Like if your bowels are all over the place, or you're having problems with incontinence, or you're so sore, you're taking so many painkillers, you're horrendously constipated, not only having a poo once a week. These are awful things for someone to have to deal with. But again, sometimes that's that reticence about people being squeamish or talking about bodily functions, and actually we just need to ask about all the nitty-gritty.
Yeah, and I guess as a doctor you've seen and heard it all, right? So you're not going to be embarrassed, or nobody should be embarrassed about talking about these things with their GP or their doctor.
Yeah, and it's what we're here to help. But also, I do acknowledge that when I go have a patient come see me in my clinic, I've got 30 minutes to see them. So I've got ages to really get through the nitty-gritty of all their different symptoms, as well as I'll be examining them and talking about different treatment options. Whereas when they come go and see their GP in the first instance, usually those appointments are pretty short. And I get my patients come to clinic, the GPs have already done most of the work for me, and they've done all various investigations, they've ruled certain things out, so I don't need to ask all those questions. So I think people should be able to go to a healthcare practitioner and feel safe and respected and listened to. But I think there's also things that people can do to help those consultations, particularly I think in a primary care setting. So if you can sit there and reflect on your symptoms, think about, are there patterns? How does it relate to your cycle? That can be a really helpful thing to mean that then at an earlier stage people start thinking about endometriosis. Whereas I think when you come with not having really unpicked it in your own mind what you're having to experience, then it's much harder in those quite short consultations to get to the bottom of all these different things. So I think that's why things like a lot of the apps that are out there, I think they've been really helpful for people unpicking their symptoms and starting to recognise some of those patterns. And it's not just how it relates to your periods, but also how it relates to things like your diet or what you've been drinking, and whether or not that's caffeine or alcohol, and how that might trigger your symptoms, because all of these things could be related.
Yeah, and I guess there's a kind of prevailing mindset that maybe GPs don't know much about endometriosis, or because there is quite a delay in terms of getting diagnosed. You hear stories in the media from women taking 8-10 years to get diagnosed. Do you think that is a misunderstanding at the GP level, or do you think it's just because it is such a whole body problem that getting down to what's actually the underlying problem is tricky?
I think there's a whole load of reasons that contribute to why the diagnostic delay is so long. I mean, in part, people don't go and see the GPs very early. So with really good data, it's quite consistent that on average, people experience their symptoms for at least 3 years before they go and seek help.
Well, that's quite a long time.
Well, exactly. So if you think about how we normalise to ourselves, how we normalise to our friends, families, colleagues about what a normal period is.
Yeah.
So people kind of go, oh, I should just be getting on with this. Or there's all that kind of shame and stigma about, am I just being a bit weak? Everyone else seems to cope. So all that normalisation, I think, is really problematic. So people don't go in for quite a while. But I think the symptoms of endometriosis are the same as quite a lot of other gynae conditions. They're also the same as quite a lot of other non-gynae conditions. And some of those conditions are potentially sinister causes. So rightly, particularly in certain age groups, a GP needs to rule out those sinister causes first, and that's totally appropriate. I think it is also difficult because, as I said, the symptoms can all be quite similar between these different conditions. And then really unhelpfully, some of those conditions are more likely to coexist with each other. So say, for instance, you've got a condition called endometriosis. We've got endometriosis. You can also have a condition called adenomyosis, which is when you've got those cells similar to the lining of the womb, but in the muscle layer. And the symptoms can be really similar. Heavy periods, painful sex. And then because of all the inflammation, you can still have all the bowel and bladder symptoms. But you're also more likely to have adenomyosis if you've got endometriosis. You're also much more likely to have IBS if you've got endometriosis. So it's tricky because sometimes if someone's symptoms in one of those areas are more prominent, then they'll go down the line of managing those first of all. Yeah. And the other thing that makes it really difficult is that we don't have very good tests for endometriosis. So it wouldn't be great if someone could pee in a pot, spit in a pot, have a blood test, and that would tell you there in your GP practice you've got endometriosis. And there isn't a reliable test yet that will do that. I'm really hopeful in the future we will, but we don't have that at the moment. So one of the things that people will typically have will be having a scan, so an ultrasound scan, so through the tummy, but actually get a lot more information if the scan's done through the vagina. And that can identify endometriosis, but it's only really reliable for identifying ovarian endometriosis or, in expert hands, deep endometriosis. So there are 3 pelvic subtypes of endometriosis. So ovarian, these big cysts that have got endometriosis-like tissue lining those cysts, so they get sort of this blood, oxidized blood-like fluid within it. So it looks a bit like chocolate sauce if you drain these cysts. So that's
And is that in the ovary?
That's in the ovary. You get then deep endometriosis when you get the fibrotic nodules of disease. But those 2 are only about 20% of the disease. So 80% of the disease is what we call superficial peritoneal endometriosis. That's these little lesions lining the peritoneum, which is the innermost lining of your abdominal cavity. You can't see those on a scan reliably.
No.
So 80% of the disease. And so for that, to reliably diagnose that at present, people have to have keyhole surgery. So that is a massive barrier to people getting a diagnosis, because to do that, you've got to go through all the checkpoints in GP going, are we missing something sinister? Are we missing something that's simple and easy to treat?
Mm-hmm.
So if people have had infection, then treating that actually is often really effective for managing people's painful periods and pelvic pain. Do they have fibroids? If we shrink the fibroids, is that going to help with their symptoms? So they go through all these sort of different treatment cycles in primary care before they typically then referred on to gynecology. And then in gynecology, we still might try some of these medical treatments. And there's also some people who there's a very high risk of doing surgery on.
Mm.
So particularly if people have had lots of operations in the past, or if they are very overweight, then there's a quite significant risk of an anaesthetic. Or similarly, if, say, you've got really severe asthma, having a general anaesthetic is a really bad thing for that.
Yeah.
So that also introduces additional barriers to diagnosis. I am hopeful in the future that we will have a test that can be done in a GP practice that will be reliable, which would be great, wouldn't it? It would make such a difference.
It does just feel like, I'm exhausted just listening to you. So to actually go through that whole process.
And every month.
Yeah. And you can see how it does just take so long to get to that end point where you at least, it's not even the end point, is it? The diagnosis.
Yeah.
I guess it's an end point in understanding maybe what's underlying the symptoms you'd experience, but then what do we do about it is the next question.
And it's difficult because sometimes those 2 things get sort of, conflated is the wrong way to describe it, but sometimes for a lot of people, knowing is really important to them. Yeah. And I get that, both if you felt dismissed, actually be able to see what's causing it. I think for a lot of people that's hugely powerful. Also that knowing that there isn't something sinister causing it. Mm-hmm. Now, that's not to say endometriosis isn't utterly miserable and debilitating and awful, but it's not cancer. And I think a lot of our patients are quite worried that there's something sinister like that underlying. So I think that relief of knowing, but also having something how you can then describe it to other people and say, this is why I have this. But having a diagnosis is, as you say, just the beginning of the journey.
It doesn't solve the problem, does it?
But then I think people are better able to focus on treatment options. And I think also in particular because, our treatments aren't perfect and they've got side effects. And I think if you're feeling like you've not been heard, if you're given a treatment which has got side effects, you're slightly like, am I just carrying on not being heard and you're just giving me this as a plaster? Whereas I think often, particularly for the hormonal treatments, once people know that it's endometriosis and they understand that they've got these lesions that have got the same hormone receptors that are in the lining of the womb, and that's why hormonal treatments are a treatment for endometriosis. Yeah. They're not a Band-Aid, they're not masking it. They actually treat the endometriosis. They reduce the inflammation. The lesions become much less proliferative, so they're not growing in the same way. But it's much easier to tolerate, I think, the side effects when you know there's a good reason why you're having this medication. Whereas I think for those who have a working diagnosis, they often feel less, or they are, I think, are less well positioned to tolerate side effects if they get side effects. I also think there's probably a whole heap of people in primary care who've got endometriosis who will never have a diagnosis because actually they go on hormonal treatment and it works really well for them. And so I think that's, we talk about endometriosis affecting 1 in 10 women and those assigned female at birth. We've actually got no idea how many are affected because in part, some people, there's so many barriers to diagnosis, but others, because they're really well treated in primary care. And so they never go down that pathway because they never have a need to pursue it because actually everything's really well managed.
Yeah, and that's great. And I can totally feel your passion for doing something about this and solving some of these problems that women are facing as you're talking about it. So tell me a wee bit about your research and what you focus on in the lab so that you can maybe take things back to the bedside.
So I'm really lucky. I work within a big endometriosis research group, and we have many different approaches to it. So there's studies we do about better understanding the disease, how it changes over time, how particularly this disconnect between disease and symptoms, and particularly like who's got their symptoms being very driven by inflammation, who's been driven by the gut, changes in your microbiome, all of those things. So understanding that symptoms, disease, and how that might mean we can be more precise in the treatments that we offer people. But I also do a lot of work in clinical trials. So that is from helping develop new medications, taking medications that have been developed for other conditions and applying them to endometriosis, but also about where the role of surgery is for endometriosis and trying to, I suppose, ultimately work out, are there ways we can predict about who's going to benefit from surgery and who isn't? Because if someone's not going to benefit from surgery, then we shouldn't expose them to that risk.
Yeah.
And at the moment, we do an awful lot of surgery for endometriosis, and we know that an awful lot of people that won't work, or that it will, if it does work, it will be fairly short term. So the more times we keep on operating, the more we're repeatedly exposing them to the risk of surgery, but also whether or not we're beginning to start causing damage with our surgery, particularly to sort of all those really irritated nerve fibers within the pelvis.
Yeah.
But the other thing there's something I'm really excited about at the moment. We're doing a lot of work of using some novel imaging approaches to look at endometriosis. As I said, ultrasound can only really reliably identify ovarian endometriosis. We use MRI a bit, which again is good for ovarian and good-ish for deep disease, but can't reliably pick up superficial disease. But I'm doing some work in collaboration with some researchers in different areas, so cardiology, imaging specialists, nuclear physicists, to look at something called PET, about whether or not that's something we could use to identify endometriosis. So PET's something we use a lot in oncology, and it can identify areas of cancer before it can be seen on a CT or an MRI. And we're trying to see if that can work for endometriosis, and that would have a few different potentials to it. So not only, can we identify the endometriosis in a non-invasive way, so people don't have to have an operation to get a diagnosis, but the approach that we are doing is we are looking about using two different radio tracers to see whether or not we can identify endometriosis as quite inflammatory or endometriosis that's very scarred, which might then have implications for what medication someone might respond to. And what I hope in the future, by both combining these approaches where we look at about what's driving people's symptoms, so are they hormonally driven, are they microbiome driven, are they inflammation driven, are they infection driven, what their actual disease biology is like in a non-invasive way. So is it scarred? Is it inflammatory? Where is it? And then also looking at their genetics to be able to say, actually, for you, for your symptoms and your disease, this would be the best treatment for you.
So it's more individualised treatment and diagnosis.
That precision-based care. And I think particularly, you talked about the BBC documentary, which was great, and I think will have done so much to empower people, make them feel heard. But I think I am really hopeful for the future. And I think that part of that is we are now trying to properly understand the biology of the disease in the way that, if we look at breast cancer, they unpick the disease. So instead of having a one-size-fits-all treatment, people have their genetics looked at, they have their tumour genetics looked at, and they have very specific treatments based on that. And outcomes are hugely better. People have much less invasive surgery. The chemotherapy regimes are much better tolerated. And what I hope is we will have that for endometriosis. So by understanding the disease, we'll have better treatments. But I think also we used to overly focus on the hormonal aspects of endometriosis. Now, there is a hormonal component, there's absolutely no doubt about that, but it is more complicated than that. And I think particularly understanding the neuroinflammation, so both all the inflammatory cells that are involved in endometriosis, but also the role of nerve fibers within it. And by reframing it as a neuroinflammatory disease, actually that allows us to step back and go, hey, there's loads of inflammatory conditions out there. So rheumatoid arthritis, inflammatory bowel disease, some of the lung conditions, and go, well, they've all got quite good drugs. So actually, rather than developing a new drug from the very beginning, which takes decades and, let's face it, billions of pounds, actually there's all these other treatments. So should we just see, they've got a lot of the same processes in endometriosis. Should we just see if we can repurpose them for endometriosis? So, I know, tricky. teaching old drugs new tricks.
I love it. No, I don't reinvent the wheel.
Well,
I mean, that's a great approach. And if you get anything, that you're looking at the moment that you think might have potential?
So one of the things that we are quite excited, although it's still at quite an early stage, is a drug called dichloroacetate. So this is a drug that's been around for about 30 years, in fact, if not longer, and used to be used to treat metabolic disorders in children. And we had a whole heap of samples that people who were undergoing surgery for suspected endometriosis very kindly gave to us. When they had their operation, we were allowed to have a bit of the tissue, a bit of the fluid that we find in their pelvis, and some of the normal associated tissue next to that. And that allowed us to see that in people with endometriosis compared to those who didn't have endometriosis, there was a whole change in the metabolism within their pelvis. So in terms of all, if you think about, if I said lactate to you, so if you go for a long run and you get a stitch, that's buildup of lactate within your muscles. And in people with endometriosis, they have much higher levels of lactate within their pelvis. And we know that this phenomenon of having increased lactate, we see a lot in cancer as well. And it helps drive the turnover of cells, growth of new blood vessels, and enabling things to stick to the sides of things. So all the things we see in endometriosis.
Yeah, that you described earlier.
And we found by giving them this drug dichloroacetate, we could turn them back to a more normal metabolic phenotype. So the cells started behaving as they should do. And then in some of our laboratory models, that shrank the endometriosis lesions, as well as, again, reducing the lactate levels and some of the inflammatory markers associated with it. So then we did a really small proof of concept study. So we took 30 women who all had this superficial peritoneal endometriosis type, so the similar to the people who'd undergone the surgery that have first driven those studies. And we gave them dichloroacetate for 12 weeks, and it didn't work for everyone, but it worked really well for a lot of them.
Wow.
So that's what we're really excited about. So we are hopefully going to be starting later this year a slightly bigger trial where we're going to have 100 people. Half them are going to have the drug, half of them are going to have a dummy tablet, and we'll actually see how we go. Because we know in the first study, everyone knew they were getting it, and that has a huge impact on how you potentially, even on a subconscious level, might report your symptoms. But it's been a really long time getting this trial off the ground. We're really grateful we got funding from the Scottish Government and the Women's Health Charity Wellbeing of Women a couple of years ago now. But it's been really tricky because even though this drug used to be used in children, it's not used anymore. So trying to get the drugs for this trial has been something of a challenge, but I think we're nearly there. And so I'll be really excited to finally get that study off the ground. But also one of the other studies we're just about to start next month is one looking at CBD. So it's all over the healthcare.
Yeah, heard about that
health aids,
on the
internet, or even if you're just going to your supermarket now, there's loads of drinks with CBD in it. So CBD is obviously one of the chemicals within cannabis. In fact, there's hundreds of different chemicals within the cannabis plant. Some of them do not very good things to you, but some of them have also got quite useful potential roles. So we know that they can reduce the cell turnover, they can have an impact on inflammation, they can also help improve sleep quality, stops on the gut irritability. So there's a few different reasons why it might be potentially quite useful for endometriosis. And so what we're using is CBD. So that's the one that doesn't, the THC is another type of cannabinoid, which is the one that if you go off and smoke something, you will get the high from it. But CBD doesn't have those psychoactive substances in it. So I think we're much more happy about both the side effect profile, but also the safety of it by just having a CBD only preparation. And you might have seen in the press a few years ago, they started using CBD to treat seizures in children with certain epileptic syndromes. So it's a very similar drug to that we'll be using. So I'm really excited to be starting that. And again, that's 100 patients. Half will get CBD, half of them will get a dummy tablet or a dummy liquid, in fact, in this case. And so I'm really looking forward to seeing the results of that trial. And I think also it's not just, it's trying to be more holistic in terms of what we look at about what's important to people. So not just looking at their pain symptoms, but also what their quality of life is, what their sleep quality is like, what their activity levels are, what all their bowel symptoms are like. And I think also trying to find different ways to assess these things in trials, because we don't, as I said, we don't have a blood test for endometriosis. We can't just do a blood test at different time points and go, yeah, it's working or not working. We ask people about their symptoms, and it can get quite exhausting, sort of continually being asked, going, tell us about your pain, tell us about your pain, tell us about your pain. And I think in some people, actually, that can be quite triggering. So trying to look at different ways of how we assess response to treatment. So we will always ask people about their experience, because that is going to be hugely important. But looking at things like using smartwatches, So instead of asking people to fill in sleep questionnaires every so often, just wear a
data.
wear a smartwatch. And that means one less thing that we have to ask people about. So I think it's these trying to deliver clinical trials in a more efficient way.
Yeah.
And I think also in the future, trying to deliver trials more remotely, because at the moment, people have to live near a research centre realistically if they're going to take part, because there's lots of visits where you have to come up, have your bloods tested, be given your drugs. And it means that also that you're more likely to have people participating in these sort of studies who live near to a research centre and also can take the time off their work and care responsibilities. So that means often the people in studies aren't necessarily representative of the whole population who've experienced endometriosis. And I think one of the things I'm always conscious with in Scotland is all those remote and rural communities that, no one can expect someone to do a sort of 4-hour round trip to take part in a study if they're having to do that 4-hour round trip every 3 weeks.
Yeah, and I guess living in more remote communities or not having access to these kind of things is an additional layer of, something that they have to experience while managing endometriosis. If your GPs know 10 minutes down the road, or your gynecologist is 3-hour drive away, actually just dealing with the disease in itself. But as you say, it kind of restricts the participation. But it sounds fantastic, Lucy, and there's clearly so many different options. And I think, so you've got the one, I'll not try and say the name of the drug, that's trying to actually treat the kind of lesion itself or the actual development of the disease.
I suppose it's more it's treating the metabolic environment around the disease. Now, in our animal models, it shrunk the lesions. But I suppose I'm quite keen not to have an approach that's purely fixated on what's happening to the lesion. It's about treating people's symptoms.
Yeah, so then your cannabinoids, if that's the right terminology again.
No, totally right.
Seems to be, more in that kind of holistic, symptomatic relief type thing, rather than specifically having an action within the tissue itself.
Yeah, and it might be doing something directly to the lesions themselves. I mean, it's anti-proliferative, so we won't get the same, growth of cells. But what it does to all your immune system, which is probably kind of overhyped, what it does to all the excitability of nerve fibers. But I think it's also what I'm really excited about. What our group does is about having different approaches to how we do our research. And I think particularly trying to enable people from all over the UK to participate in research. And I think that's why I'm really excited by our Endo 1000 project, which is seeking to recruit 1,000 women and those assigned female at birth with endometriosis. But they never have to come anywhere near a research centre. So they do it all from their homes. So tracking their symptoms through an app, which I think people are much more used to doing now with kind of all these period and female health, women's health apps. But doing all these biological specimens from the comfort of their home. And I think post-COVID, people are a bit more used to the idea of, you do a swab and you stick it in the post. So we can now get people to do a pee sample, a poo sample, a vaginal swab, spit in a pot, and also can do a little finger prick test to get some blood. And we can do it. We can get an amazing amount of information from a few drops of blood just from a finger prick test. And they can put this all into their post. And going back to your comment about when people are really struggling with their symptoms, so having a flare, there's so much we don't understand about flares. We know for some people they're very linked to where they are in their cycle, so they're quite predictable. But for some people they're really unpredictable. And I think those who have unpredictable pain flares, it's really difficult to mitigate that. If you know it's linked to your cycle, you can plan your life slightly around it. Now, ideally no one should have to plan their life around it, but at least you can plan.
Yeah.
Whereas for those people who have those unpredictable pain flares, and they can happen at exactly the wrong time, but if you've got a big party, you've got a presentation at work, it's your child's Christmas play or something like that, all of things, and then you get a pain flare out of the blue, that's really hard. And we really don't understand them, because historically that's not going to be a time anyone wants to get on a bus or get in a car and come up to hospital. Whereas allowing people to do these samples from home, it's the work of minutes, and then someone else can take it off and pop it in the post for you. And that, I think, is going to be really powerful in Endo 1000, of particularly understanding about what drives pain flares and also how things change over time. So many studies have just been done on this single snapshot time point. And we know the disease is really dynamic, both in getting worse, but also getting better. So we've had studies in the past where people have had keyhole surgery to diagnose their disease, and then as part of clinical trials, it's not been removed. And then people have gone back in 6 months or a year later to go and either plan treatment to the disease or just to see what's going on as part in the context of a clinical trial. And some people, the disease gets better of its own accord without any hormonal treatment. And we don't understand why that is. And if we could try and work out what are the factors that allows your body to fix itself, wouldn't it be great if we didn't have to give people these medications with side effects and or typically many of them are contraceptive. Wouldn't it be great if we could harvest other ways of trying to enable the body to fix itself?
Yeah, it does seem like it's such an individual disease. And I think your approach of looking at it like that and thinking, understanding all the different factors that go into it is really brilliant, and hopefully it will end up, giving us some answers in the future.
And I'm really hopeful for the future. I think it's taken us a long time to get there, but I think it finally, across all women's health, it's getting much more of the attention that it deserves.
Definitely.
I hope that will then follow with funding. But I think also that is also going to enable us to have the tools to unpick the disease the way that we've seen in different cancers. But I think also that we're also conscious that some of this will be a numbers game in terms of just having enough samples from enough people. And so what we try to do is work really collaboratively. So almost all of the big endometriosis centres, research centres globally, we've all signed up to something called WRF Effect, which is the World Endometriosis Research Foundation. Harmonising and phenotype. I've got the last bit wrong, but it's WRF Effect is the key thing. But essentially, it's a series of guidelines about if you're getting samples from patients, what questions everybody should ask, and how you should process that samples. And that actually allows researchers from all over the world to pull those samples because they've all been collected in exactly the same way. And so that allows you to have much more diversity in your cohorts, but also to have big enough studies to be able to get meaningful insights.
Questions.
So some of the work that's been led, particularly by researchers at the University of Oxford, have led to really fascinating insights about the genetics of endometriosis. But the only reason those have come through is because they're big enough studies, so it's people sharing all their samples. So I think that sort of mobilization of all the research units trying to work together and not being super competitive with each other, but actually go, look, all of us aim to make this improve outcomes, and so we've just got to work together.
Yeah, I think that's becoming a wee bit more common now. I think COVID did flip the switch in that a bit because we saw the evidence of what happens when globally if we all get together as researchers and pool our resources, pool our funds and pool our knowledge and our expertise into trying to solve a specific problem. And it's great that endometriosis is one of those problems that we're trying to solve with that. But I think you've taken quite a unique approach with the Endo 1000 project as well, because I know you're trying to recruit kind of through using social media and allowing people to donate specifically directly to your research within the university. So I mean, it's all these new ways of working to try and get that funding and to get that awareness out there at the same time. How have you found that working?
So it's interesting. I suppose we're all very used to trying to get funding from the big, funding bodies. So from the government, from health charities, we're all used to going through that. And we tried to get Endo 1000 funded that way for, I want to say nearly a decade. And we went to so many different funders and they kept saying, this is a great idea, but it doesn't fit our remit. And so in a way, it feels slightly uncomfortable going to different organisations, so different companies, philanthropies, so charitable trusts. But actually what's been amazing and a real privilege to be kind of see as actually all the patients and how they've helped, from doing things like doing free tattoos to raise money, doing kilt walks, doing other fundraisers, to help support this research. And, it's terrible that patients are having to raise the money themselves, and that shouldn't be how it is. But I've been in awe of those who've made it happen. And it has allowed us to get off the ground and get going. And I think equally, you see this in so many, startups, etc. Once you get the ball rolling, then it's easier to find more investment. And we are beginning to see that come through. Some of the larger organisations are now being incredibly generous. But it's at times it's felt a bit uncomfortable kind of saying, do you want to help fund this? But I think actually for some of the people who've helped fundraise for it, it's been something that they found really powerful, and I think also created a sense of community. I think any chronic pain condition has a huge amount of stigma and loneliness with it. And actually what some of the individuals have done to kind of come together as a community to help fundraise actually has been something that's given them benefits as well as what they're doing to help us in supporting our research. So It's been an amazing thing to be part of. But as I said, I'm in awe of all those people who have come up to help. In the same way, they're an amazing group of people to work with from the research perspective as well. And I'm always astounded by their generosity of time, what they'll go through to help us try and get to the bottom of the disease. And I think one of the things that does drive that is that there is a genetic component to the disease. And so a lot of women say to me that, I recognise that this probably won't help me, but I know my daughter's got a chance of getting this awful disease. And actually, hopefully this means that when she has it, she will have more choices.
Oh, that's lovely. So. It's always the same, the kind of research that I'm involved in as well. The patients who are willing to participate kind of always blows me away. So what number are you up to then? You want to recruit 1,000 women. How many have you recruited
me on
already?
The spot. Oh God.
Ballpark figure.
Oh, I'm going to be in so much trouble. So we cancelled our weekly update meeting this morning because lots of people are away. I think we've got thousands of people who've signed up for the app. You can't enter into all the biological sampling until you've done a certain proportion of the tracking. And so, inevitably these things, no one's going to fill in the trackers perfectly, but we need them to be reasonably good at it before we'll invite them into doing all these samples, because then we want to have the people that we know are going to be able to do the samples at the beginning, samples after a flare, and then samples in 12 months, or if they have an intervention like an operation. But we've only started recruiting earlier this year. And I know we're certainly, in terms of people who've done the samples, we're into the hundreds who have done that first part. So it's been really. I'm going to be in so much trouble that I'm going to have to send you the updated figures so you can flash up over what I was meant to say about the current numbers. But it's been great, and I think we're doing this in collaboration with a group of researchers in Croatia as well. And so that'll be really fascinating to look at, because obviously their diet is quite different over there. And I think what we'll be saying about diet and endometriosis in 5 years' time will be really different to what we're saying now, and particularly having evidence about what the role is of the microbiome, what about different dietary choices might mean for your risk of symptom flares. But also we're hoping to expand it out to Ireland later on this summer, which will be great. It's been a great project, but I think also the endometriosis research community is not that big. And so, other researchers globally are seeing what we're doing. And so what I hope is that we're all going
to get in on the action.
Yeah, do it in the same way. And again, rather like with the Worth Effect project, that we can then all pool our samples, and is particularly having this, what we call longitudinal data. So people being sampled at different time points rather than this single snapshot that's so informative. Are really about how this disease changes in time, because I think it sort of feels like you're constantly working with running sands of, you have this time point and then things have instantly changed, not just for the, across the disease, but for that individual.
Yeah.
And also what their needs are at different time points in their life. So yeah, as I said, it will be a numbers game, but the Endo 1000 project, particularly, I think enabling people who historically wouldn't have taken part in research to be part of it, I think has been really powerful.
Yeah, it's fantastic you're already up. It sounds like it's going to be the Endo 10,000 project.
Well, I think Andrew Horn, who set the whole Endo 1000 project up, I think secretly he wants Endo 1 million.
Well, maybe we'll get there. To have that uptake in such a short time, and if you're branching out, collaborating with other research places across the globe, it could end up, a massive global effort. I think what you have started here has been fantastic, and I think the research has actually helped raise awareness of the disease as well. And it's lovely to see that kind of partnership. I know you work with different endometriosis charities and, as you say, communities within patient groups and things like that. So it's a lovely kind of symbiosis where you're kind of helping each other.
I know, and I think we're really fortunate in those communities and patient support organisations. But when we were setting up the Endo 1000 project, we had quite a lot of talk and discussion about what our tagline should be, and then eventually we went, actually, we just need to talk endo. And part of this is all about awareness and advocacy as well. But I think the other thing that has been really useful is us not working in silos. And so a lot of the approaches we're having are things that I was going to say stolen, but that's not really the right word. But things that, say, gastroenterologists have been doing with inflammatory bowel disease, or what people are doing in the cancer space, and going, well, actually, our disease shares commonality with your diseases, and what can we learn from your the decades of research has gone there, that actually we can then not short circuit, but take a shortcut to apply to our own disease. And again, that's one of the things I really like about being at the University of Edinburgh. So I work in the Institute of Regeneration and Repair. So we've got people who are working on inflammatory biology across so many different conditions. I think that's been really helpful for us. And then in my imaging project, I'm working with cardiologists, liver physicians, gastroenterologists. And again, where we can learn from each other, I think, is really important.
But that's just efficient, for want of better words. There's no point trying to start from scratch if there's already knowledge out there. And that's what I love about working here as well. There's so many different things going on. But it sounds like there's real positive developments happening and a real positive outlook for the future. So what would you say to anybody listening who's currently undergoing endometriosis or experiencing it and is feeling a bit dejected? Do you think there is hope?
Oh, I absolutely think there is hope. I think some of those there are a lot of new treatments on the horizon. I think we will have to recognise there will never be a one size fits all. And even if something works well for someone at one point of their life, their needs might be different at a different point of their life, but we can usually make things much better. What I also really hope is that it's not just the people who've got endometriosis or on that diagnostic pathway, that they get to a diagnosis and treatments much more quickly. What I find really difficult is that time before first seeking help seems to just not be changing despite all the advocacy and awareness. So anyone who is missing school or having to take time off uni or missing days of work because there's a problem with pelvic pain or with their periods doesn't just put out with and go, this is part of being a woman. Or someone who menstruates, and they go and seek help, but also they get heard when they seek help.
Yeah. So if anybody wants to find out more about Endo 1000 or is considering participating, where should they go to find that information?
I totally should have come. I'm going to that. So go to our Expect website. So that's Expect with two P's. So EXPPECT. Oh my God, my dyslexia is totally coming out.
I'll put the link in the show notes.
Or the Endo 1000 website. Yeah. I would also say there is some great information at Endometriosis UK, Wellbeing of Women, and also NHS Inform have all got good information about endometriosis and pelvic pain, as well as particularly Wellbeing of Women and NHS Inform about other aspects of women's health and periods, menopause, because all of these things can be really grim.
Yeah. Well, thank you so much for your time today, Lucy. It's been fascinating hearing about all that research that's happening. And I think it will be a real beacon of hope for everybody listening. But my final question for you that I ask everybody is, what is the one thing they didn't teach us in sex ed that they probably should have?
So I think it's that your period shouldn't be so sore that you're missing something. That's not normal, and seek help.
That's great advice. And they should teach that in sex ed. Thank you so much. It's been brilliant.
My absolute pleasure. Well, thank you for having me on.